treat the color change.
So it's classically acholiuric. That's the answer.
That's why it's called acholiuric. There is no bile.
Yes.
So read the basics. Okay, we'll continue later. LVK, we can start.
Yeah, ma'am.
Yeah.
Can we have the next slide? Who is taking up the case?
This is okay. Bhargav. Bhargav, and who else is with you? Who else is with you?
I think Parag.
Parag. Okay, you and Parag. Okay. Start.
Yes, ma'am. So here is a 63-year-old female, known case of diabetes mellitus, hypertension, and coronary artery disease, who is on medications, presented with chief complaints of generalized itching for past 8 months, abdominal distension for past 1 month, pedal edema 1 month, decreased appetite for 3 weeks, and loss of weight of 10 kgs.
Yeah.
Yes. Itching started in the soles and hands, progressed to all over body. It was treated with emollients.
Any other information you want in the itching?
One thing is whether it is generalized itching or localized to
She
specific
started
parts of the
with
body.
soles and hands initially. Now she has got generalized itching.
Yes, sir.
You need to ask what is the time the itching is more. Is it nocturnal itching or?
Yes, sir.
So
Whether it aggravates during the evenings and nights.
So nocturnal itching is something which is more commonly associated with liver disease. Okay.
Yes.
Then
So it was treated with emollients.
she was treated with emollients, but there was no response at all to that. She continued to have generalized itching. Started with soles and palm. I had generalized itching for last 8 months. Okay.
Yes, sir. Sir, whether any history of jaundice was associated with this itching?
Not at that point of time. For 8 months, not at that point of time. For the initially, it was only the itching which was going on. There was no history of jaundice at the onset of itching. That's the most important. Okay. She had only. She didn't.
Sir, any history of
She did not
fatigue?
notice any icterus till she went. But 8 months she was going on with itching, and she was seeing some local doctor. There were emoluments and antihistamines were given, but it was no this one.
Yes.
Yeah.
So progressive abdominal distension for past 1 month, which was followed by pedal edema. So onset of abdominal distension, I would like to ask, and how was the progression?
It was
gradually progressive.
It was a gradually progressive abdominal distension. There was no pain, and she found at the same time this was followed by pedal edema.
Yes. Urine output during this period.
The urine output was, she says, it was fairly well preserved, but she had some mild, no abdominal pain, but she had bilateral loin pain.
Yes. So she noticed a mild increased color of the urine for past 15 days.
Before she came to us, then she found that after 1 month of abdominal distension, which was progressive, and pedal edema, she found that she had a high colored urine.
Yes. Sir, during the seen by local doctor and documented to have mild jaundice, patient had fever for 1 week before admission.
Any other history you want?
What are the other questions you'll ask in a patient now who's got jaundice, who's got itching, and who's got abdominal distension? What questions will you ask? Now, just etiology, what are the etiological questions that you'll ask? Patient diabetic, hypertensive?
We just find out, yeah, she's a diabetic, she has got systemic hypertension, she's got coronary artery disease.
What are the drugs she's on? Won't you ask all that? What are the drugs?
Yes, ma'am. Yes, ma'am. I would like to ask what are the drugs she's taking, and whether this abdominal distension was associated with any breathlessness on exertion, which has progressed over.
The drug she was taking was for the coronary artery disease. She was on statins and ecospirin, and for this she was on gemfloxacin and Gemfloxacin is one drug which she was taking. Recently, she was changed over to gemfloxacin, and then she was already on metformin. And for hypertension, she was on telmisartan, 40 milligrams.
Yes, sir. Sir, as itching was for past 8 months, were there any alternative system of medication for itching, like Ayurveda symptom?
She has been taking for 4 years medications for diabetes. She says apart from this, she was also taking some Ayurvedic medicines for 4 months. And once the itching developed, the doctor changed that Ayurvedic medicine to another medicine. So she was taking this, plus for diabetes, she noticed she was taking some alternative medicines. And after she went and complained to the local doctor that she is having itching, he changed out to another medicine for this. And she has been taking this medicine for 8 months or 6 months or so. And then she stopped after the local doctor has told and documented her mild jaundice.
Yes.
So that's the history she has. She has a history of coronary artery disease, diabetes. She was on glimepiride, gemfloxacin, and then she was on medication for diabetes with this thing for 4 years. Now recently, that Ayurvedic medicine has been changed to another medicine after the onset of pruritus. This is the history she has.
Yes, sir.
Yeah. Can we go to the next slide?
So there is no history of vomiting or hematemesis, no melena, no history of any altered sensory, no arthralgia, has loss of appetite for past 1 month, and noticed progressive weight loss. It was about 10 kg, which was mentioned previously.
5 to 10 kg, that's what she documents. That she is not able to eat after the onset of mild jaundice, okay, and abdominal distension. Progressive abdominal, she was not able to eat. And her nutritional intake has progressively come down after the onset of abdominal distension.
So in spite of abdominal distension and pedal edema, she is losing weight. No, that means usually when people develop abdominal distension and pedal edema, they have to gain weight. So the weight loss must be quite profound in this case. Yeah.
So what do you think that weight loss could be?
Weight loss,
meaning weight loss, or she is meaning muscle loss?
Sir, muscle loss.
Probably she is having muscle loss. Yeah. Okay.
May I ask a question? What about the skin lesions? Did she have any skin lesions to begin with? Did she have any skin lesions at any time during the course, or at least towards the fag end of the lesion? And what is the relevance of skin lesions?
Sir, skin lesions, we can look for any signs of malignancy, internal sign.
No. Here it
No.
is.
In this,
long-standing pruritus. What are the skin signs you look for?
Long-standing pruritus. What do you
long-standing pruritus,
do?
Yeah.
Think of
Long-standing
the
pruritus.
possible diagnosis and whether there can be a skin manifestation. That's one thing. Whether there can be secondary effect due to chronic itching. Okay. As an infection and other things. Okay. Think of any etiology where the skin also can be affected, which will present with the pruritus for a long period, and at the fag end the person may decompensate.
sir, I would like to consider autoimmune, some of the autoimmune conditions
There are
that can present with prolonged
there are any
colitis.
skin lesions. She can have skin lesions because of prolonged itching. Okay, she can have scratching that would have got infected. Sir wanted that. Or
Yes.
there can be a disease where there could be itching, skin lesions, and lead on to liver disease. Number third, the scan can also produce sometimes
Itching.
skin lesions, isn't
Skin
it?
lesion.
The skin
Yes.
lesions in a drug-induced liver injury could be associated with vasculitis, or it could be associated with erythema multiforme. So you can have this or that. So this is how you interpret it.
Yeah, and not to
And
forget xanthomas, xanthelasmas and all, no?
Xanthelasma osmosis.
So now 6-8 months now. See, the jaundice has come on much later. So this will be the classical presentation of long-standing pruritus. No, then you see that as you examine the case, and you know that it is something like secondary biliary strictures and all will present as. Usually by 3 months, 4 months, they'll fade. They'll have a liver cell failure. But all these prolonged polystasis, you have to look into all this. So read up the skin manifestations of polystatic jaundice. Okay, related
Okay.
to
This
unrelated.
case is interesting because long duration of pruritus,
Yeah.
then jaundice, then possibly
And
decompensation. We have no
then
idea. Yeah.
with drugs, both recent gemfloxacin as well as CAM for nearly 4 years. Recent change in
Change in
CAM.
yeah.
So this is what you need to focus on. Yeah. Go ahead.
Yes.
Can we have the next slide, please?
She is a non-diabetic for 10 years, history of alternative system of medication for diabetes for 4 years, stopped 3 months ago. Has no family history of liver disease, no risk factors for chronic hepatitis. No surgeries in the past. She consulted local doctor and ultrasound showed shrunken liver with moderate ascites. Referred for
So
admission.
found she was icteric. She didn't notice icterus. The last 15 days after 15 days after developing abdominal and fetal edema, she noticed high colored urine. That's the time she went to a local physician. He saw her being icteric and ordered an ultrasound. An ultrasound showed shrunken liver with moderate ascites. But she was
Yes.
referred for evaluation here. Any other questions you need on her? Why the risk factors for chronic hepatitis is very important in this?
Yes. Any history of blood transfusions in the past is an
Why?
important.
Risk factors of chronic hepatitis can be blood transfusion, surgery, then
Tattooing.
tattooing, dental extraction,
Yes, sir.
or any other interventions, or blood donation. Even blood donation is also important. Okay? We don't
Yes.
know how they have taken the donation.
Yes, sir.
So why is it important? Somebody has got itching for 8 months and then decompensated. Which hepatitis will produce itching?
Autoimmune hepatitis.
Which hepatitis among B and C can come with cholestasis?
Oh. C.
Hepatitis C can come with cholestasis, isn't it? So they can come with
Yes.
itching. Chronic hepatitis B does not come with itching, but acute hepatitis B can get itching if they go into cholestatic phase. But in chronic hepatitis, hepatitis C can come with itching, no? Because C can also produce bile duct damage and bile duct injury. So that can produce itching. Itching can be a feature of chronic hepatitis, right?
Yes.
Okay.
PFIC in a younger age group. PFIC 3.
Madam?
PFIC 3 in a younger age group.
Yeah. PFIC
3.
in a younger age.
Type 3. Yeah.
But here, the pruritus preceded jaundice by nearly 6 months. That is most important here. So that's what you need to think of, right?
So you want to continue with the history?
Can we go to the next slide? Or
Next slide. Okay.
Okay, now,
What
can
are
you
the
just summarize her history?
Sir,
And what do you think
sir,
she has? Imagine how old is she? 63, no? 63 years.
yes, sir. So this is a
Any other
63-year-old
history you
female.
want? Any other history? Keeping in background the differential diagnosis. Any other history you want on her?
Sir, arthralgia has been mentioned. Joint swelling.
Arthralgia,
Joint swelling. Any
alopecia,
drug she's NSAID intake.
arthralgia. I don't know what will be relevant for immune mediated. This is arthralgia, alopecia, or was she found to have any hypothyroidism? Because they can have
Yes.
sometimes autoimmune thyroiditis, which can precede these liver disease much earlier. Okay, all these things are very important. Was she treated for hypothyroidism?
And anemia. Autoimmune hemolytic anemia.
And
Anemia.
anemia. Did she have any fatigability? So, lady coming with long-standing pruritus and thing when you're thinking of an immune-mediated arthralgia, alopecia, fatigability. Fatigability is very, very common with autoimmune liver disease. And then any history of being treated for hypothyroidism. Remember, she is also a diabetic, isn't it? She is also
Yes.
being a diabetic. This is what I think you need to think of.
Can uremia present as pruritus, Bhargav?
Yes, ma'am.
Uremia, yeah. Uremia,
Yes, ma'am.
diabetes, they're all actually initial presentations.
Yeah. When do diabetics come with, diabetics can come with
Pruritus, yeah. Urticaria,
pruritus?
yeah. Diabetes
One,
per se can come
if,
Yes.
if they have a very uncontrolled
Severely
diabetes.
uncontrolled diabetes.
controlled
Or
diabetes.
two, when they develop diabetic nephropathy and uremia, so they can come with
Severe
pruritus,
pruritus.
severe pruritus. So, and the pruritus could be because of this. So here the pruritus could be because of diabetes. She can have an underlying liver disease. Can be due to CAM also. We don't know. Can be due to CAM also. Okay.
Yes.
Okay. So now can you summarize who is taking the case? Parag, Dr. Parag.
Yes, sir.
Bhargav, you summarize and let him take over. Bhargav, summarize,
Yes.
discuss.
So here is a 63-year-old female with known comorbidities of type 2 diabetes for past 10 years on alternative system of medication for diabetes until 3 months ago, developed progressive pruritus for past 8 months, developed abdominal distension in the form of ascites for 1 month, which was associated with pedal edema, and noticed jaundice for 1 week, which was associated with fever.
There was one history fever.
There was history of loss of appetite and significant weight loss also in the patient.
She had fever and loin pain.
Yes.
Fever and loin pain. She is a diabetic. Okay.
Yes, sir.
That's important, right? So what do you think so? So she was found to have a shrunken liver. She found to have ascites. She was found to be icteric. She has decompensated in way of ascites and pedal edema and jaundice. And now she has got these are all preceded by 8-month history of pruritus, history of OHA, and history of CAM.
Yes. Sir,
What's your
my
syndromic diagnosis is what, Bhargav? Be fast. Polystatic jaundice.
Polystatic jaundice.
With liver cell
I'll
failure.
consider chronic liver disease in the form of cirrhosis of liver, decompensated with ascites, type 2
Underlying-
diabetes mellitus.
Underlying liver disease. Underlying liver disease.
Underlying liver disease, I'll consider cirrhosis of liver.
Due to
It can be due to diabetes per se or drug-induced liver injury, alternate system of medication.
NAFLD, no? So she's likely to have an
No.
underlying NAFLD.
You can have a lot of differential diagnoses.
Yes.
Here is a lady who is 63 who's been long-standing diabetes. She has
Yes.
been taking CAM for 4 years. Now she has decompensated with ascites, pedal edema, and jaundice, with preceded by a pruritus for about 8 months. Okay.
Yes.
So she also has got coronary artery disease and systemic hypertension, right? So what are your differentials in this patient? So what are the differential diagnoses for her chronic liver disease? She has definitely got a chronic liver disease because an ultrasound showed shrunken liver with ascites.
Yes, sir. Sir,
Tell me the possibility of
etiologically, I will consider viral hepatitis, underlying viral hepatitis, chronic hepatitis B, and I will also consider hepatitis C in this patient.
chronic hepatitis C, I will first in her.
Yes.
Chronic hepatitis C, I will first put her in, and then maybe okay. So
I
viral.
will consider
There is a viral hepatitis.
non-alcoholic fat.
Wait.
Non-alcoholic fatty.
One you think it is chronic viral hepatitis. It could be hepatitis C or B. Okay. Okay.
As diabetic for past 10 years, I will consider non-alcoholic fatty liver disease as etiology for underlying chronic liver disease.
Alcoholic fatty liver disease. What do you call? What is the terminology you use for her?
NASH progressing to
NASH-related
cirrhosis.
cirrhosis.
NASH cirrhosis.
NASH-related cirrhosis.
You should know the terminology. Non-alc
Yes.
NAFLD is steatosis. NASH is steatohepatitis. NASH can progress to fibrosis. It can progress to cirrhosis. So this is probably shrunken liver. So she has got a NASH cirrhosis, which is gone. But she has got a weight loss as well as pruritus.
Yes, sir.
Do you think there can be any other complication on her?
The weight loss, what are you called?
HCC, hepatocellular carcinoma,
Very
can
you
cause.
of a HCC also in this case. So hepatitis C
Yes.
with HCC is also a possibility in this case. Number third,
Yes.
here is a lady who has got pruritus much before the onset of jaundice.
Yes, sir. As
year-old.
yes, yeah. Pruritus, I will consider only because of liver related. Non-hepatic causes also has to be kept in mind.
No.
As
If
ma'am
No,
told,
no, no.
causes,
uremic related pruritus.
if there is a
PBC,
lady
PSC.
who has got pruritus preceding it and then decompensated, what are your differentials in this?
Autoimmune
Apart from viral,
also I will
apart
keep.
from NAFL, what can you think of? Think of an immune-mediated liver disease like
Primary, yes, biliary cholangitis, primary sclerosing cholangitis.
Number two,
Primary sclerosing cholangitis.
primary sclerosing cholangitis.
I will also, it can be an
Or
overlap.
can be
Autoimmune hepatitis with
excellent.
PBC or PSC.
AIH over, so she can have ALPS. Remember, this sort of slowly going through and then decompensating slowly and mild icterus is more common with PBC rather than PSC. When you have primary sclerosing cholangitis, the jaundice is very striking and then they go on to decompensate. PBC can go on, become fibrosed, decompensate, and you can get jaundiced. So, or it can be an AIH with an overlap. Okay, with an overlap. So these three you will consider as immune mediated. Both can always be drug induced. Can, you know, the CAM sometimes can produce it can be sometimes
It can cause hepatocellular or cholestatic.
Yeah, it can be fibrogenic, it can be cholestatic. Okay, since it's shrunken, probably it has produced cholestasis, and the cholestasis has gone on to produce probably fibrosis.
Secondary
Fibrosis and the decompensation.
Yes.
What's the question, Ashwin? What do you want to ask? Someone has raised the hand. Ashwin? Unmute and what's your question?
And with the intrahepatic cholangiocarcinomas secondary to cirrhosis and hepatitis C, ma'am.
No, we'll come to malignancies. Then the other thing is you can come to malignancies. In malignancies, you'll think of HCC or a
Yes, sir.
cholangiocarcinoma.
Okay,
but cholangiocarcinoma will not present like intrahepatic cholangiocarcinoma will not present like 8 months of pruritus followed by this one. Okay, very unlikely. But I would consider malignancy 63 years, decompensated liver disease with anorexia. Probably I think HCC is one thing. Intrahepatic cholangiocarcinoma will be a close differential diagnosis. But if you are thinking of an underlying chronic viral hepatitis C or a NASH related, I think HCC is much more common. Okay.
Yes.
In a cirrhotic liver, you know now that there is you can get HCC, you can get intrahepatic cholangiocarcinoma, and 18% of them you can get hepatocholangiocarcinoma. That's a big thing where it is from. This will.
Yes.
Anything else, madam? Anything else, Dr. Varghese, sir?
I think that's fine. Yeah.
No, if we didn't have the history of ultrasound, I think we should also have considered hepatic venous outflow obstruction also at the fag end.
Yes.
Because the cause of decompensation could be due to like a hepatic outflow obstruction secondary to drugs, either modern medicine or CAM.
A good diagnosis to think
DD,
about.
yeah.
So because CAN can produce sinusoidal obstruction sometimes, and it can produce Budd-Chiari like picture. Fine. That's also fine. That's the other thing. Because most of these are plant alkaloids which can produce sinusoidal obstruction. I think that's something which we need to consider. So we'll consider viral hepatitis, C, Hep B, probably superimposed with HCC. You can consider NASH because she's diabetic, coronary artery disease, hypertension. NASH with CAM causing cholestasis, decompensation, and severe weight loss, probably for the SCC. Third, we'll think of immune-mediated liver diseases like PBC, PSC, or overlap. Fourth, we need to think about, as Sir said, some vascular diseases because of the drug, sinusoidal obstruction, and going on for a hepatic venous flow obstruction.
Yes.
Move on to examination. Examination.
Can we go to the next slide?
Parag?
Yes, ma'am. So on examination, we had mild icterus. She was conscious and oriented. Pallor was present. There was no cyanosis, clubbing, lymphadenopathy, or pedal edema. Vitals.
I'll just stop here. Are you, Bhargav, see, icterus itself was seen by some doctor. What's your comment with this mild icterus in this patient? Mild icterus with so much of cholestasis. So what are the other possibilities? See, you're surprised, no? With so much of cholestasis.
This icterus can be a part of decompensation. I don't think it's a part associated with itching.
Or hemolytic. It can just be part of, it's very mild, no? I'm surprised. It can be just part of hemolysis because that alternative system medicine, just keep that in mind.
Yes.
All right. Yeah, the mild icterus is something little out of the box, no? I would have expected deep jaundice by now. That mild icterus. Okay, continue.
Vitally, she was stable with BP of 110/80 and pulse rate of 80 beats per minute. On core abdomen examination, abdomen was soft, liver was palpable 2 centimeters below the costal margin. The left lobe was prominent. Liver was firm in consistency. Spleen was palpable 3 centimeters below the costal margin. Free fluid was present. There were no dilated veins.
There were no dilated veins in the abdomen, flanks, or in the back. Okay?
Yes.
That's what you always look for, right?
So, in a patient, a female patient with a hepatosplenomegaly, what are the things that cross your mind? Keep your video on.
It's not getting on.
Okay, just tell. So, you're surprised, no? Because one
Yes.
report you got ultrasound is showing shrunken liver, and now you have a hepatomegaly with a splenomegaly. So, in a female, what are the other things that cross your mind? And with the weight loss, Bhargav?
Granulomatous.
No, more common, hepatosplenomegaly with weight loss. I'm giving you a clue, female, postmenopausal. Hemochromatosis?
Yes.
Yes.
Keep in mind, you have to keep in mind because it is surprising, no, to see a large liver, which can occur in cholestatic jaundice. But then just keep in mind, there's a weight loss there. What you cannot explain is, but suppose this case comes as a short case bedside clinic, and you have a female with a hepatosplenomegaly, no veins. Yeah, and there's a diabetes. You understand? And a weight loss. So just we are giving you a clue. Postmenopausal hemochromatosis has to be kept. It's high risk for malignancy.
Yes.
So
that context.
Can you go back? At the end of this finding, that
1 minute, LBK. So at the end, 1 minute, LBK. So just remember, if you have to see hemochromatosis, see that you've done a cardiovascular detailed examination. Don't miss on that. Hemochromatosis, you'll have a dilated cardiomyopathy. So have a wide perception. Don't get focused because someone has said it's a shrunken liver and you're in for this thing here.
What is the other important examination you'll do in this patient? You'll look for skin lesions, you look for any scratch marks, all those things, because she's been having pruritus for 8 months.
It's a mountain,
Does she have
hyperpigmentation.
Any shiny nails, all those things are very important. Some of the examiners will expect all these things.
Yeah.
Does she have lichenification of the skin? Did she have any healed vesicles or any scarring because of erythema multiforme? All those things need to be looked up in all these patients. Okay?
Sure. Yeah.
Yes.
Because you always, when you have a drug-induced, they always look features for any cutaneous vasculitis, all those things. Very, very important. Rash.
Yeah.
Okay.
And because BT also mentioned HVOTO, see that veno-occlusive disease, you may find that the HJR is negative. So please look, see, be very careful, especially with a large liver. You must examine the. So what is your comment on around this left lobe? Left lobe prominent. What is your comment on that?
Whether it can be due to, if you're thinking of malignancy, whether it can be due to the mass
It's
per
only
se.
a firm liver. It's only a firm liver.
It could be a differential enlargement because of
Yeah,
small liver.
yeah.
Lobe is prominent, right lobe is not prominent.
It's a
So just go to
differential.
the differential enlargement of the liver.
Yes.
Okay.
It's a differential enlargement. And what else? So
And
now
when
you can suspect malignancy with a hypertrophy of one lobe to the other lobe. All these should come in your mind. Why is one particular lobe more prominent than the other?
Yes.
Yeah, that's the way your mind should work. That this patient has got a splenomegaly, has got no veins, ascites is present. One lobe, that is whatever is felt in the epigastrium, is significant. So just keep in mind, are we having an atrophy hypertrophy complex? Actually, there's actually a malignant process. What's happening?
Yes.
Not at the level of the liver, but at the porta. It may be extending there. So any of that would cause this differential enlargement. Okay.
Yes.
Yes. Should we mention lobes?
Normally, we don't mention the lobes because of this atrophy hypertrophy complex. The best, simplest would be just mention the liver in the mid-clavicular line and mid-sternal line. That is safer. You'll be safe. But HDR has to be seen in this patient, all right? Okay. Okay.
do you have any change?
And other important thing is in all these patients, just remember the other complication is the hepatopulmonary and portopulmonary hypertension. So just see that you've taken an SpO2, look for platicnia. Because she's come with ascites and edema leg. So keep all the complications in mind. There's no GIB, there's no SBD, there's no apparent renal insufficiency, breathlessness is not there. So just hang on to what we always teach, no? And then in the lung, just ensure that you've not missed a HPS, or at least, so you can pick up a POPH with a right ventricular hypertrophy. Okay, HPS can be picked up with an SpO2. Simple test, bedside. And then do not miss an MHE. Do not miss an MHE. Either she may be having uremia and there's encephalopathy, or she has what's it called, liver disease and MHE. So when you say other systems normal, please in this particular case you have to do a detailed examination of the cardiovascular system, because hemochromatosis will come as a DD. Pruritus is not an onset, agreed. But after the examination, it has to come as a DD. See that you've done a detailed CNS examination. She's a diabetic. She may be having neuropathy. Look for trophic ulcers. Have an open mind. The examiner can ask any question anytime. You cannot just make a passing statement, CNS is normal. You have to do the test. Ask her whether there's any numbness, whether there is any odd sensation in the feet. And you must do the MHE in this patient, no? Because ascites is present. And she's 63 years old. All right?
Okay.
And if there's a HCC, paraneoplastic manifestations like polycythemia. These are all the paraneoplastic manifestations. So supposing there's more of polycythemia than pallor, then your mind should just shift towards a HCC. Okay? Okay. These are some of the clinical findings that many of the examiners ask. Okay. What is the question? Who is asking a question? Just raise your hand. Please ask. Please ask your question.
Somebody has asked whether rectal examination findings should be mentioned
Not
here.
required. Not required. No,
Yeah,
not
because
required.
that pedal edema, both are there. And if it's a pure ascites, maybe. If there's bleeding here, we have to. There's no doubt about it.
Okay. So after this, does it really change in your
Yeah.
differential diagnosis?
Diagnosis,
I think you
yeah.
can stick on to this. But I think we should add on hemochromatosis, as Madam said, because long-standing diabetes, hemochromatosis can have pruritus, all those things. Because hemochromatosis can always be complicated by HCC. That's one thing which can come. Okay. So I think we'll still stick on to viral, we'll still stick on to NASH related, we'll stick on immune mediated outflow, sinusoidal outflow obstruction and hemochromatosis in this patient. Probably superimposed by a small chance of HCC because of severe anorexia and weight loss.
Yeah.
Okay.
Agree.
And as Manson said, because she said there was a weight loss in spite of edema, we thought it's sarcopenia. So whenever patients are sarcopenic, we should look for minimal hepatic encephalopathy. MHE is very, very common.
And
Okay.
also do a detailed nutritional assessment. See, those are the things that are missing here. Look for a midarm circumference, some gait test, walk test, balance test, do few tests
This thing.
because you commented on sarcopenia.
Yes.
So how do you want to investigate this patient?
First, we'll do the basic investigation, sir. First, we'd like to know the liver function test.
Can we have the next slide?
Doctor, would you not ask for a CBC in this patient?
Yes, ma'am.
That's
Hemoglobin,
the first thing. No, how in a patient, what's the first investigation that you ask?
hemoglobin and complete hemoglobin.
Yeah, you want to know. Supposing the platelets are low, you already made a diagnosis of advanced fibrosis
Yes, ma'am.
and autoimmune hemolytic anemia. So first is a CBC. Why should you ask for an LFT? Supposing the examiner says, what are the two or three important investigations which will give you a clue to the diagnosis? Then you jump to the LFT and whatever you want to say.
Yes.
But if it's a case for management, this is a long-standing patient who needs management. So would you not? Okay, come on, move on.
Yes.
CBC.
On investigations, hemoglobin is low 9.9, MCV is low 77. Total counts are 5,900. Differentials of 64% neutrophils. Platelets are 1,80,000. INR is 1.19.
What's your comment?
Iron deficiency anemia is there, ma'am, on the CBC.
But what is surprising? The platelet is normal, no?
Platelets are normal.
Platelets are normal, ma'am.
The platelets are normal. You would have expected this shrunken liver and all those things that were mentioned. And there is a portal hypertension, but the platelet is normal. So when can platelet be normal? In such a situation, in such a patient, when can the platelets be normal or on the high? You have to suspect MPN. Always keep that in mind. Yeah, we keep that in mind. Yeah.
Yes.
Okay.
LFT showed a total bilirubin of 2.5 with direct more than indirect, 2.2 direct and 0.3 of indirect bilirubin. SGOT and PT are normal. Total protein is 6 with AG reversal. Albumin is 2.4 and globulin is 3.6. Alk-Phos is elevated 190 and GGT is 62.
What's your comment on this? So there's AG reversal, there's raised alkaline phosphatase, there's hyperbilirubinemia.
Is there, sir, with hypoalbuminemia. That might explain the pedal edema, sir, and the abdominal distension.
Okay. Well, next, what do you want?
Bhargav, keep interacting. Just both of you, just quick.
What is the other thing what are the investigations you want now?
Sir, ultrasound abdomen. In case of blood investigations, I would like to ask for viral markers.
Viral markers.
Ascitic fluid analysis.
Ascitic fluid showed a low protein, high SAR, and no SBP. Ultrasound showed. No, can you just show me the ultrasound report here? Yeah. There was only mild ascites. She was already given diuretics by elsewhere in Kerala, but she had a splenomegaly. Ultrasound here showed a coarse. Yeah, go ahead, Bhargav.
Ultrasound showed liver coarse ecotexture, nodular surface, portal vein is dilated, mild ascites, splenomegaly 14.3 centimeters. Ureoscopy lacks LES, grade 1 esophageal varices with severe portal hypertensive gastropathy.
Yeah.
What next?
Viral markers.
Can you go to
I would like to ask.
Look at the.
Look at the blood sugar and creatinine. What do you ask all that? Diabetic.
Yes, ma'am. I would like to ask for fasting and HbA1c levels for her. Whether how is the glycemic status?
So 9.9%. Yeah, HbA1c is 9.9%.
This thing, and she had a low sodium.
Low sodium.
And creatinine was 1.21. Potassium was 4.14.
Yes.
The low sodium could have been due to she had mild,
Dilutional hyponat.
she had mild enough. So she's got
Sir,
hyponatremia.
yes, sir. It can be due to dilutional hyponatremia.
Why did I check a serum cortisol?
One of the cause for hyponat.
What could have caused low cortisol?
As she was on Ayurvedic medication, it would have caused cortisol suppression.
Yeah, that is one thing. Could it be drug induced this thing?
Adrenal
Or-
insult.
Or was it dilutional?
Yes, sir.
Or was it depletional? Okay.
Yes. Yes. Cortisol was 21.
Serum osmolality was more than urine osmolality, and the spot sodium was 31. So possibly it was a depletional because she was already on diuretic. Okay.
Yes. Urine
We always
PCR.
in hyponatremia thyroid profile because we thought of an immune mediated liver disease. So was she associated with
Yes.
it? Or sometimes when you have hypothyroid, what can happen to the sodium levels?
Hyponatremia. One of the.
You can have a false hyponatremia due to hypothyroidism. Her
Yes.
viral serology was negative. Hepatitis B, C, anti-HBC total were all negative.
Yes. Yes. Next, I would like to ask autoimmune.
So she has a depletional hyponatremia. She's got anemia, AG reversal. She has got mildly elevated globulins, and she has viral serology is negative. She has possibly a depletional hyponatremia, normal renal functions. Okay, creatinine is 1.19. I don't know, with the
Yes.
presence of probable sarcopenia, that may also be high. Okay, urine spot sodium is more in feature of doesn't conform to HRS AKI in the presence of hyponatremia because your spot sodium is 31.19. So she was treated with diuretics. Probably she came with that combination of diuretic and low salt intake. Okay. So we have seen sometimes this happening in the camp. We always check when they have hypotonia because a lot of people have adrenal insufficiency, especially when they take Siddha medicines, which contains sometimes steroids. Okay.
Yes.
Yes.
Then, can we go to the next slide? Yeah.
So fasting lipid profile, total cholesterol of 110, triglyceride 109. It was non. HDL is a little bit low. Anemia profile, ferritin is 255, iron of 24, and TABC of 240.
And what do you want here?
IG.
Madam was telling about hemochromatosis.
Yes, sir.
Transferrin saturation was, I think transferrin saturation was 48.
Yes. Basically,
What level of
serum
transferrin
iron
saturation you will have this thing?
more
If the
than
ferritin is
55.
grossly elevated, what are the possibilities in this patient?
Sir, one thing is in anemia it can get elevated, and one more thing is acute phase reactant.
I'm saying supposing this ferritin has been 850 or 900.
Yes, sir.
What are the
I
possibilities of
didn't
high ferritin in this patient if she had had a ferritin?
Sir, one
Having
it could,
overload state, or NASH can have elevated ferritin, isn't it? NASH can have.
Yes, sir. Yes, sir.
Number 3, she's a diabetic. She had loin pain and fever. She could have a pyelonephritis infection and an acute phase reactant. These are 3 things which thing.
Yes.
Then
As we are suspecting hemochromatosis, we should suspect
transferrin
hemochromatosis.
saturation was only 48. It was not elevated.
Yes.
Ferritin was not
Yes.
grossly elevated. This is one of the things why we
Yes.
did an anemia profile on her. Then go ahead with the investigations, please.
Yes. IgG levels are 23.29. Serum ceruloplasmin is
What do you
43.
think of IgG levels?
IgG levels are elevated.
Yeah, IgG levels are elevated. Anything above
Yes.
16 is elevated.
Yes, sir, normal. 23 is elevated. Ceruloplasmin is normal.
Hmm.
ANA is negative. ANA profile when done,
The
JO1
Joe1
is,
alone was positive.
yes. Liver profile, LC1, EMA M2 is positive.
So since he came with an ultrasound elsewhere, we went
Yes.
ahead with the
Either higher imaging of CT abdomen.
yeah. So what is the purpose of doing CT in this?
Sir, in this patient, CT to rule out any focal lesions.
One focal lesion. Number two,
Uh,
hepatic vein outflow.
yes.
Because she has been taking CAM, so we need to think of it. Can we have the next slide?
Sir, CT abdomen showing normal sized liver. Surface nodularity is there. There is widening of fissures and mild caudate lobe hypertrophies. Not able to see any focal lesions in the liver.
There
Sphenomegaly
is
is there.
one focal lesion on the left hand
Okay, sir.
column. They have seen one focal lesion. They have described one focal lesion in the segment 6, I think. Let's go to the report.
CCT abdomen shows shrunken liver with prominent caudate lobe and left lobe. Hypodense lesion measuring 4 into 3 into 3 centimeter in segment 8. Superior lateral right lobe of liver, mild capsular retraction. Possibility confluent hepatic fibrosis or cholangiocarcinoma. Bilateral emphysematous pyelonephritis.
So she had bilateral, but there was one hypothesis which was not characteristically enhancing with the thing. So they said, is it a confluent hepatic fibrosis or a cholangiocarcinoma? So the prominent cartilage, prominent left lobe, shrunken liver, but hepatic veins were patent. Okay.
I think that capsular retraction gives a clue, no?
Is a clue,
Cholangiocarcinoma.
but it could be cholangiocarcinoma. That's one important thing. Non-enhancing lesion with the capsular retraction could be a cholangiocarcinoma. Okay. This is one thing. I think somebody brought it up this much with him. I think very good they brought it up this cholangiocarcinoma. Can we have the next slide? So what do you want now?
Tumor markers. Serum AFP and CA19.
Yeah, go ahead please.
Serum AFP is normal, 2.13. CA99 is elevated, 32.9.
Okay.
Not very much elevated, but in the upper
Not
end.
the level of cholangiocarcinoma. Okay.
Yes, yes.
So now what do? We don't know whether this thing or what is it you want to do?
Sir, as mild ascites and INR is normal, we
So
can go
CT
for
has shown a hypodense lesion, non-enhancing. So we don't know whether it is a cholangiocarcinoma or a confluent hepatic fibrosis. What do you do now?
Yes.
Should
Sir,
we do
either
any
we
other
can go
imaging
for,
to sort it out?
yes, sir. We can go for MRI abdomen.
Very good.
MRI contrast.
Yeah, correct. Can you go to the MRI?
Yes.
Yeah. Can you see that? Segment.
Yes. Hyperintense lesion.
With not much of a diffuse restriction. Okay. Can we go to the report?
Ill-defined, wedge-shaped area in segment 8 of right lobe with capsular retraction and mild dilatation of the biliary channels within the lesion. Possibility is focal confluent fibrosis.
Fibrosis. So what do we do now?
LVK, what is this focal confluent fibrosis?
No, this is what happens is in anything fibrotic when there is one single hypodense lesion, the other lesions may get attenuated. That's what they said, and this could be one area of fibrosis may be getting little highlighted. So this is what they call it as a focal confluent fibrosis. That's what they said. It did not look like a cholangiocarcinoma. Okay, and it is not HCC because it was not really enhancing like a HCC.
Yes.
So what do we do next?
Sir, it's difficult to get this lesion in ultrasound abdomen, so we can go ahead with CT-guided biopsies.
Okay. Can we have the biopsy?
Bhargav, what has happened to the DILI now? Do you think now the DILI is excluded? No, now we have, the direction is now to move towards PBC.
Delhi certainly not excluded. Maybe the Delhi has caused a lot of fibrosis.
Yeah, underlying
It
fibrosis.
can be,
Sure.
yes,
So
ma'am.
some of the
Drug-induced
diseases,
autoimmune
some
also.
of these camps can be fibrogenic. Okay, so please do not can be fibrogenic.
NAFLD can go to HCC. That's one. Hemochromatosis can go to HCC. And HBV or HCV, all markers are negative. Okay.
All the
So
markers are negative. AMA M2 is positive. LC1 is positive. IgG is elevated. There was confluent fibrosis, ascites, portal gastropathy. So we have done a biopsy on this.
what was the report?
Can we go to the next slide?
Liver biopsy showing sections
Can you
show
read
liver
the whole,
tissue.
can you read the whole thing, please?
Yes, sir. Microscopic appearance section shows liver tissue exhibiting distortion of lobular architecture with extensive portal fibrosis and focal parenchymal nodules. Hepatocytes are arranged in single cell plates in most parts. Swelling of hepatocytes and focal anisokaryosis are noted, along with occasional multinucleate forms. Focal macrovesicular steatosis and focal cell necrosis. Sinusoids are dilated, Kupffer cell activity is evident. The wide areas of fibrosis involving portal areas show marked ductular proliferation, many dilated portal venous channels, and dense lymphocytic infiltration. Lymphocytic infiltration of duct lining epithelium is noted in foci. Loss of bile ducts, however, is not detected. Interface, ductular reaction, and lymphocytic infiltration are seen in some parts of the section. Diagnosis.
This biopsy shows one lobular architecture is distorted. There is portal fibrosis. There are parenchymal nodules because of fibrosis. There are also, you can see the sinusoidal dilate. That means there is sinusoidal fibrosis also there. And there is also ductular involvement with lymphocyte infiltrations. So this could be, patient has presented to you with intense pruritus much before the onset of decompensation. So this could be probably involving, they said it could be a primary biliary cholangitis, primary biliary cirrhosis. Okay, that's one thing. There are some focal macrovascular steatosis, but they did not say any much of Mallory Denk or ballooning to say that there is a NASH in this, number one. Number two, there is an element of portal fibrosis, architecture distortion, there is ductular involvement, there are sinusoidal involvement. Okay, mainly because there is a sinusoidal involvement, a sinusoidal fibrosis, probably she developed ascites with a bilirubin of 2.2. Okay?
Yes.
And there's a profound ductular involvement, ductular damage with the lymphocytic involvement. So this is possibly a right. Then we discussed whether this could be CAM induced, but they didn't see much of eosinophils or plasma cells in these patients. So this is basically a
primary
biliary cholangitis presenting in this patient, decompensation. And she had emphysematous pyelonephritis. And she had fever and loin pain, for which she underwent bilateral ureteric stenting. Once we controlled the infection, she started becoming better. Okay.
Sir, I have a doubt whether this was taken in the lesion or in the normal.
It was one taken, I think one was taken in the lesion. That's why they have excluded the neoplasm in the lesion. Okay. So, management issues in this. Madam Varghese sir, anything else?
Fine. Only thing, that's what, as Dr. Varghese also said, you have to have a wide differentials, no?
Yeah. The wide
I think, to me, liver is quite simple,
We worked all the differentials we looked into.
Yeah.
We looked into viral, we looked into immune mediated, we looked into NASH, we also looked into hemochromatosis. We did a CT to rule out hepatic vein obstruction. But the biopsy has shown all the three. So now the interpretation of liver biopsy, we need to look at the portal fibrosis, we look at the sinusoidal fibrosis, okay? then perivenous fibrosis, all those things we need to look at very, very separately. I think this is what I think the other time in Goa, what's his name? Arun Sanyal was talking that we need to talk about portal fibrosis again. It is no longer that fibrosis. So in the porta, arterial loss and all. The only thing we asked was, is the whole thing could be CAM or is it CAM induced auto? We didn't see much of plasma cells or eosinophils in these patients.
998-793. 8793.
Can I have the next slide? So final diagnosis, Bhargav.
Sir, final diagnosis in this patient will be primary biliary cholangitis with underlying cirrhosis, decompensated in the form of ascites.
No. Decompensated chronic liver disease, got cirrhosis of liver. Etiology is primary biliary cirrhosis with comorbidities of
Diabetes, hypertension, and coronary artery
disease. And okay, and she had a bilateral liver which stented. So how do we manage this patient?
Sir, management in this patient. First, I would like to build her up nutritional wise.
Somebody asked for IgG4. IgG4 would have shown definitely in the liver biopsy, number one. Number two, they all come with jaundice and severe pruritus. IgG4 does not precede this one. IgG4 can be, but this is not the. They'll also have involvement, some sort of a thickening or what caused a decompensation. Now it would just be biliary cirrhosis and fibrosis. Okay. Yeah, any primary biliary cirrhosis can lead on to decompensation. That's why we transplant. And
can pyelonephritis be the cause for decompensation?
It is not an overlap syndrome. That's what I was telling you. It was not an overlap syndrome, mainly because we didn't see any intense, what we call it as interface hepatitis, or we didn't see any plasma cells, or we didn't see any this. Okay. Only spotty necrosis, and there was ductular infiltration by lymphocytes. That is probably what it taught them. It could be a primary, right?
Yes.
Management issues.
Sir, management, building her up nutritionally, giving her.
What will be the specific drug you like to use?
Sir, deoxycholic acid.
At what?
At least 13 to 15 mg per kg per day.
Yeah, that's what. Sir, Varghese, sir, you want to say something?
No, in the differential diagnosis, there are some drugs which can produce chronic cholestasis, especially pruritus dominant and subsequently evolving into secondary biliary cirrhosis like a picture. But usually we call secondary biliary cirrhosis when there is a mechanical obstruction. But in the case of drug-induced cholestasis, sometimes the extrahepatic biliary tract also can undergo fibrosis. For example, phenothiazine group of clopamazine and all those drugs.
Amiodarone.
Yeah, notorious to produce chronic cholestasis and finally evolving into decompensation, something like biliary cirrhosis decompensatory. So that theoretically they should know that there's a possibility like that. Okay. I think this is a very good presentation of a primary biliary cholangitis presenting with pruritus for a long period, and then at the fag end of the story, the patient decompensated with jaundice.
What is
natural history? That's what I feel.
Only thing is that the onset is pruritus is little uncommon in PBC, no? It is fatigue is one of the presentations. Fatigability. So I think
I don't know. Pruritus was drug induced or
was it most probably was drug induced, yeah.
Or it could have been due to diabetes.
Or diabetes. That's what.
I think it was quite some time back, and I think most of our people, especially people working at home, usually don't mind the fatigue part of it that much. Only when there's a significant symptom, probably they will attend to a doctor. She might have had fatigue, probably it was attributed to something else because she had diabetes and so many other illnesses to begin with,
So it
That
must
may
have
be
got masked.
yeah.
So any role of liver transplant, Bhargav?
Ma'am, currently, I don't think there is, because her MELD is less than 15 and decompensation can be due to emphysematous pyelonephritis or some other cause. So once we treat the cause, if patient is uh, recompensating, then right now there is no indication for transplant.
I think with the nutritional
Fine.
management and high UDCA, she did very well. And as you said, when we put the stent on either side, the counts came down from 21,000. Sometimes she developed during the time, then came down, and then she became much better. Her stent was recently removed, and now I saw her 2 days back. Her LFT has normalized. Her pruritus has come down. She is responding very well to ursodeoxycholic acid. I think the first line will be there. Of course, please read up about other things. What will be the problem of giving obeticholic acid in this patient?
Sir, patient is already having pruritus.
Very good. So,
Obeticholic acid, one of the side
may
effects is
worsen,
pruritus.
obeticholic acid may worsen her
Yes.
pruritus in this patient. Somebody raised a hand. You want to ask any question, please?
Actually, my doubt is clear. I wanted to know what is precipitated the decompensation of. So it is a natural
Decompensate
history.
could be a natural history, and there could be some infection which could have decompensated.
Okay. Thank you, sir.
Can we go to the next case quickly? Anybody else is doing the second case?
Dr. Nihal,
Hello, sir.
Nihal and Sai Kiran Mayush.
I'll start, sir.
Yeah.
Sir, we have a 45-year-old female with a history of systemic hypertension. Now presented with complaints of yellowish discoloration of eyes and urine for 1 month. With pain in the right hypochondrium since 1 month. And weight loss of 5 kgs in the last 1 month.
So what do you want to ask her? She has come to you, 45-year-old lady. She has come, known case of systemic hypertension.
Yes, sir.
She has come with yellowish discoloration of eyes and urine for 1 month, pain in the right hypochondrium for 1 month. And she says she has lost weight of 5 kilos in 1 month.
So first I want to ask history suggestive of obstructive jaundice, whether it was associated with itching.
There is no prurite. First, something I'll ask is there any prodrome?
Okay, sir.
Huh? Okay. So
Yes,
one
sir.
is you wanted itching. Okay. There's no, I don't think she had pruritus. No.
Okay, no pruritus, yellowish discoloration of eyes and urine, color of stool.
Stool, there was no pale color stools.
No pale colored stools.
There was no prodrome. There was no itching.
No fever history.
Pardon?
No fever history, sir.
No fever. No fever.
No fever. History of intake of CAMs.
Yeah, she had a history of intake of CAM because she went to a doctor earlier because she was feeling very fatigued, and she said somebody looked at it and she said that she had a mild jaundice, and then she went to a local doctor because she went for a treatment for jaundice, and she was given CAM for about 3 weeks or for 1 month. Yeah, 1 month she was given CAM, and then she started developing yellowish discoloration eye and urine.
Okay.
But the reason for going to doctor
Was initial
with
jaundice.
CAM was she was feeling little tired and she had mild jaundice, and she was told that she had mild pallor.
Yes, sir.
Mild jaundice, fatigability, and pallor. And she took this medication. And 1
After
month
which-
after the medication, she started having a profound discoloration of eyes and urine. And she had then pain.
Yes, sir. So then pain.
And after 1 month, anything is history in the jaundice you wanted.
Any.
We asked about prodrome, we asked about fever, you asked for You asked for CAM, I told you. Then
Blood, any 45-year-old blood transfusion or anything, sir? History of
the
blood
history present. She's been having jaundice for 1 month. She has developed jaundice 1 month after CAM. Along with jaundice, during the progression of jaundice, you have to ask whether she has developed a pedal edema or ascites.
Yes, sir.
So, supposing she has developed a pedal edema or ascites during this 1 month of jaundice, what is your interpretation?
One is I would consider a patient post intake of CAMS with worsening jaundice and ascites, acute on chronic.
The patient has taken CAM.
Yes,
She
sir.
has developed jaundice and she has come to you with 1 month history of jaundice. Say 2 weeks or 3 weeks later, when she had jaundice, if she has developed ascites or pedal edema, what does it tell you?
I would consider acute decompensation of an underlying chronic liver disease.
Yeah, one, she may have an underlying chronic liver disease, or
Second,
what will be the possibilities of underlying chronic liver disease?
45-year-old female. I would like to only this hypertension is there. Probably.
No, doctor, I'm asking a very simple question, doctor. You said she's got an acute and chronic liver disease. What are the possibilities of chronic liver disease in this particular age when you have considered an underlying chronic liver disease?
Viral.
Viral,
Then autoimmune.
autoimmune,
NAFLD, non-alcoholic steatohepatitis. Yes,
Wilson's.
Wilson's. Hemochromatosis.
Okay, if it is not a chronic liver disease, when do they develop ascites?
Okay. Not a liver disease. Sir, patient can develop if there is a Budd-Chiari. Basically,
When there is, we had an entity called subacute hepatic failure. So when there is a submassive necrosis of the liver, you can develop ascites. Okay.
Yes,
Okay.
Yes. Then I would like to ask whether there were noticeable distended veins in the abdomen, sir.
How many times you have seen a patient coming and telling you that I have distended veins in cirrhotic liver or in a chronic liver disease? No.
Yes, sir.
So you ask other attendant questions. If
Yes,
she has
sir. So,
edema or abdominal distension, or does she had any features of a GI bleed, like a hematopoiesis or a melena, or
yes.
she develop any encephalopathy? These are the questions you have to finish it off when you are asking when the patient has got some progressive jaundice. So this will tell you whether this patient has had an acute hepatitis like picture, or she has developed something like an ACLF, something like that. Okay. That's what you should say. Don't go say, I want to look at Budd-Chiari and say, I want to look for distended veins. Huh?
Yes.
You have seen a lot of cirrhotics, no?
Yes, sir.
How many of them have come and tell you, I have distended veins and I've got to look at it? No.
Zero.
They will have, yeah. So these are questions you will ask pertaining to her progression of the of her jaundice. And
Yes, sir.
pain in the right upper quadrant.
Pain in the right hypochondrium, is it a continuous?
Tell me, what are the details you want about the pain in the right?
Character of the pain, sir. Is continuous or intermittent?
Okay, one is a character pain, number two.
Then site is mentioned in the right hypochondrium.
Right hypochondrium. Character is a dull, aching, continuous pain.
Dull aching, continuous pain. Radiation of the pain.
There was no radiation of the pain.
Increasing and decreasing factors.
Not really. It's a continuous dull, aching pain and weight loss of 5 kgs in 1 month. So somebody 45-year-old has got a jaundice.
Yes, sir.
Weight loss of 5 kgs in 1 month. Pain in the right hypochondrium.
Yes, sir.
What will be your differential diagnosis?
Pain in the.
Possible. That's how you think of, no?
Yes, sir. One is I would like to consider biliary calls, sir.
Sai, you can also interact. Yeah.
So what do you think of? Somebody says a 45-year-old lady comes with
Tell your differential, Sai.
with the yellowish discussion for 1 month, weight loss and pain in the right hypochondria.
Yeah, Sai. You're muted. You're muted.
Considering the dull nature of the pain and
Now just give you a differential. Yeah, don't keep. Let's just tell what are the possibilities.
one can be an acute first presentation of a CLD.
With the weight loss, doctor is emphasizing again and again.
It's an underlying malignancy.
Three prominent symptoms are right upper quadrant pain and yellowish discoloration and weight loss.
Yeah,
so one is malignancy is important. No? Carcinoma, gallbladder is one. Hilar cholangiocarcinoma is two. Sometimes patient can have a chronic HBV and present with HCC, which can have pain and jaundice, isn't it? Isn't it? You can have intrahepatic cholangiocarcinoma extending into common hepatic duct, producing pain, jaundice, and weight loss. Don't worry about the case now. This page, we are still in the history, and this is what you think of. Okay?
Okay.
So we dissected the jaundice, we dissected the thing, and we looked at the pain. So these are the broad differentials you will have when the patient is present to you or sitting as a consultant. Okay? Can we go to the next slide?
No prodromal symptoms were present, no itching, no pale colored stools, had upper quadrant pain, dull aching continuous in nature, no relation with food, weight loss of 5 kgs in 1 month.
Yeah, I think we have covered most of it, and then we'll go to the next slide, please.
No arthralgia, noticed alopecia for the last 15 days, no previous history of jaundice, had tiredness and fatigability. Last 1 month, due to anorexia, intake of food had considerably been reduced. No melena or hematemesis or altered sensoria. History of native medicine intake for fatigability and was told to have mild jaundice. She took
taken for medicine. So she had fatigability, she said, and she was told a mild. So she went to a person who is practicing AIH, and then she has taken some medicine. So that mild jaundice and fatigability. Somebody looks at small icterus and fatigability. What are the possibilities here?
We just discussed that in the previous case.
You get icterus
PBC is one possibility, ma'am.
One can be hemolytic anemia.
Yeah, one hemolytic can be there. Number two.
Liver related, it can be an.
No, let's talk about. See, she had some fatigability, and somebody told her she had jaundice, so she went straight to a fact person who takes native medicines. Okay. So where do you get that mild icterus without too much of prodrome, this thing, what will run into your mind? So one, you said hemolytic. Number two, can you have B12 deficiency? Where you can have mild. Can B12 deficiency produce icterus?
Yes, sir.
How does it produce?
Because of ineffective erythropoiesis and.
Very good. Ineffective erythropoiesis, you get it. Number three, she possibly would have had a Gilbert syndrome, isn't it? This is what happens majority of the time. Majority of the times, they may have Gilbert's or a mild hemolytic anemia. If she has got a hemolytic anemia which can produce mild jaundice, what are the hemolytic anemias you can have that mild jaundice? Thal what? Thal is thalassemia trait or what?
Traits.
Trait. Thalassemia trait can have mild jaundice. Okay. Or you might have mild erythrospirocytosis.
Yes, sir.
Sickle cell trait. All these things can produce. So she actually had a mild this thing. And if you looked at her LFT report before she went to take the CAM, the bilirubin was 3.2 and direct was 0.8.
Indirect.
She had some mild indirect hypoglycemia. First she went and had CAM. And 4 weeks after CAM, she developed jaundice. So, but this jaundice was not accompanied by was not accompanied by any
Pruritus.
decompensation, GI bleed, or encephalopathy, but she had the right upper quadrant pain and a weight loss.
Arun, what's your question? Arun and Andy. Arun, what's your question?
Uh, I'm Andy. Good evening, ma'am.
Ask your question.
Ma'am, as per the chief complaint, can the pain and jaundice be due to viral hepatitis?
Why not?
In this case,
Can be. So let's not come. We are not come to the differentials. So this is what the history is going on, and let's see what's next. We'll talk about the differentials. Okay.
Ma'am, Arun here, ma'am. Actually, my question was regarding, ma'am, last case, not about this case. My question was how obticolic acid can cause, ma'am, paradoxical this rise in pruritus. So it is a bile acid, it will decrease the bile acid levels.
Which one? Obitocolic acid. No?
Yeah, ma'am. My question was regarding last case.
I know. I understood last case. What was it? Obitocolic acid and?
How it can cause pruritus, ma'am? It's actually paradox, ma'am.
Yeah, it is a paradox. That's why people say, no, there's a pruritus. So patients on obitocolic acid develop pruritus, and then they say, okay, you give drugs for pruritus and continue with obitocolic acid. That's one group. The others, when the person already has pruritus, I'll definitely not take a risk of adding obitocolic acid. It is a paradox. Exactly. It is a paradox. I agree. Okay, continue.
Can we go to the next slide? So at the end of the history, what do you think are the differentials in this patient? So 45-year-old lady,
Non-hypertensive.
Summarize this history.
45-year-old lady, non-hypertensive, now has presented with progressive jaundice after intake of CAMs.
4 weeks after intake of CAM, she is developed with progressive jaundice with no prodrome, decompensation, or cholestatic symptoms. She historically she had a report of indirect hyperbiliemia for which she has taken CAM, and now she has progressed to jaundice. Okay.
Yes, sir.
So what are your differentials in this patient?
Differentials
She had
are,
some fatigability and she had some alopecia.
yes, sir. So with history of fatigability, alopecia, or already underlying some amount of
Hey,
icterus.
what do you do with the drug itself? Yeah, I don't know.
Yes, sir.
Okay, what are the differentials in this patient?
One is one I would like to consider B12 deficiency, sir, because
No, this patient here, you come with a progressive jaundice, man.
okay, one is drug-induced liver injury, sir.
Yeah. So drug-induced liver injury, number one. Number two.
Number two, with associated history of right hypochondric pain and weight loss.
No, one in say now this could be one. You said drug-induced liver injury.
Just give your diagnosis, doctor. Don't keep on discussing the case again.
Even don't describe it. I want. See, we know. See, I'm saying that this lady has got a right upper
Already
quadrant,
same
weight loss,
thing we're
jaundice,
repeating. Yes.
history of CAM. So now you need to think of one could be drug-induced liver injury. You can explain the dull aching pain made by because of liver enlargement or due to hepatitis. So one could be drug-induced liver injury, drug-induced hepatitis. She doesn't have decompensation. She doesn't have cholestasis. So it could be an idiosyncratic drug-induced liver injury. Number two.
Autoimmune hepatitis.
Viral hepatitis, you need to always think about it. Okay? Viral hepatitis is the two. Number three, autoimmune hepatitis is a possibility. Autoimmune hepatitis could be de novo or
Precipitated.
Drug-induced, CAM-induced.
could be drug induced.
By delay.
So there could be what is called as DILI induced AIH. So DILI can cause idiosyncratic, it can cause cholestatic, it can produce hepatocellular, it can produce cholestatic, it can produce mixed, it can produce autoimmune hepatitis. Third possibility, I would certainly not rule out malignancy.
Malignancy, weight loss is there, no?
Weight loss, 1 month of history of jaundice, 5 kg weight loss, and this thing. I will not rule out a malignancy. In this malignancy, we will think of GB malignancy, hilar cholangio. We'll think of even a HCC in this patient. If HCC is a possibility, the underlying liver disease could be due to
Viral hepatitis.
what virus? 45-year-old lady.
Hepatitis B, sir.
Correct. She might have an underlying chronic hepatitis B, and now she could have come with HCC, isn't it?
Yes.
So these are the things, possibilities I would think of. Ma'am and Dr. VT sir, Verghese sir.
Fine, LVK, yeah, we are with you, yeah.
Can you
It's
go?
Because of
Yeah.
like in the other case, whenever somebody has a short history of pain and jaundice, again, venous outflow obstruction is to be kept in mind.
Yeah. Vascular disorders. Sinusoidal obstruction syndrome.
On examination.
Findings on examination.
Can we go?
Yeah.
On examination, she's conscious 2+. Otherwise, no pallor, no cyanosis, clubbing, or lymphadenopathy or pedal edema. Blood pressure systolic is on 100, pulse rate of 98. Per abdomen, liver palpable 2 centimeters below the coastal margin, no free fluids, no dilated veins, no splenomegaly. Other systems are within normal limits.
Next.
Basic lab parameters, CBC, hemoglobin is 10 with an MCV of 85. Total counts are 6,600. Differential counts are normal. Platelet is normal. INR is elevated, 2.29.
From the history, can you totally rule out extrahepatic biliary obstruction in this patient?
Extrahepatic? No, ma'am, because patient has presented with pain abdomen.
So you cannot rule out. So what were your differentials for extrahepatic?
Extrahepatic, I would consider one is gallbladder.
Just be, yeah, one is gallbladder malignancy. Number 2 is it can just be a biliary stricture, no, with progressive jaundice.
Yes, ma'am.
Yeah, suppose especially if the liver is palpable, you find the liver is large, it may not be totally obstructed, but in any patient polystatic jaundice of this type, even though you don't have pruritus, you have to consider both the possibilities. Just keep a balance, like IgG for cholangiopathy, all these other causes, the new age cholangiopathy, IgG4 related, PSC, small duct or large duct. Keep all the differentials possible, or you have to discuss extrahepatic versus intrahepatic in such patients. Okay. The points in favor of intrahepatic is far more than extrahepatic. But any patient, the pain is usually not so much of a feature unless you have a sudden stretch on the capsule. It's
this short history pain. Tell them that I've considered extrahepatic because of short history of jaundice pain in a 45-year-old lady. That's where.
Yeah.
Okay.
Hilar cholangio present just like this.
This one you need to think about. Okay.
So what are the lab values? Bilirubin 25.4.
25, ma'am. Direct hypertension.
Yeah, fine.
SGOT, SGPT, SGOT more than PT, 639 and 289. Albumin, globulin 3.5 and 3.4. Alkaline phosphatase is normal, 106. DGT is mildly elevated, 94.
So total bilirubin is 25.4. SGOT is more than SGPT. PTINR is 2.29. There is no AG reversal. Alphos is normal. Gamma GT is mildly elevated. So what do you think they have?
It could be an hepatocellular. Looks like hepatocellular pattern, sir.
Hepatocellular jaundice with some positive active hepatitis going on in this patient. Okay. SGOT more than SGPT.
Do you want to calculate the R factor in this patient to know whether it is, suppose it's a delay?
You need to take R factor in this. R factor came as 6.
It's more towards polystatic.
R factor is 4 or 6. I don't know. Dhanush is there on the line.
Dhanush, what was it? R factor?
R factor was 4.
You can just divide it and check. Okay. So.
Okay.
Sir, any relation for significance for monocytosis in this patient? 14%.
Not really. I don't know. Could be drug induced or something.
INR is prolonged.
INR is pro.
INR is prolonged. Albumin globulin is
Yeah.
fairly
Oh,
maintained.
she has got an acute liver injury.
Acute liver injury is there, exactly.
So she doesn't only have acute hepatitis, acute liver injury. So she doesn't have encephalopathy. So she don't have ALM, but she's got acute liver injury.
Hi, Kiranmai. What did you have in mind when you asked about monocytosis in this lefty picture? With this,
EBV virus also can sometimes cause monocytosis.
EBV virus will not
monocytosis.
produce so much of jaundice. EBV virus and CMV will not produce so much of jaundice. They produce mild
It is herpes is producing. Yeah.
and they will not produce so much of jaundice. Herpes simplex, yes, they can produce, but enzymes are not in favor of herpes simplex. In herpes simplex, the enzymes will be in thousands. Okay. Next.
VT was what was in your mind?
No, because he asked monocytosis. So I was at
Yeah.
I knew that he was thinking about Epstein-Barr virus, and the clinical picture is not typical.
Yeah.
They don't produce 25 jaundice and both CMV and EBV
The
never produce.
initial picture will be like a more prodrome, feverishness, fever, and all those things will be much more than a common viral hepatitis.
Okay.
Yeah.
Can we go to the next? What do you want next? Can we go to the next, please? These are all okay.
The story short, what's the next investigation you want?
These investigations are normal.
Sodium potassium is normal by coming.
Yeah, that's all normal.
You need an ultrasound, no? You need an imaging. That's the first thing that you need in this
Yeah.
patient.
Can we go to imaging? I think we did it.
The other thing that you should keep in mind is,
She had
gallstone, gallstone in the Hartmann's pouch presenting as varices. They're also present like this.
Ultrasound done elsewhere shows mildly coarse liver, portal vein mildly dilated, no ascites, no splenomegaly. Upper JSCOP shows lax ileus with grade C reflex esophagitis and no varices.
Okay. So it showed some mildly coarse liver. It was a little hypoic. That's what they have put it. She patient has come from Salem. Portal vein was mildly dilated. No ascites, no splenomegaly. Nothing much big. We didn't see any focal lesion. We didn't see any intrahepatic biliary radical dilatation. Okay. We did an endoscopy, and endoscopy showed some grade C reflux esophagitis. There were no varices or portal hypertensive gastropathy. So there's no portal hypertension. Some coarse liver. Sometimes in acute hepatitis or hepatitic form, you can get a little hypoechoic liver, and sometimes you may have an increased extension. Can we go to the next slide?
Viral serology was negative for hepatitis B, C, A, as well as E. Ceruloplasmin levels were slightly on the lower side, less than 20. 24-hour urine copper, that is high, 153. D-penicillamine challenge test positive.
Not much. No, generally you expect more than 4 or 5 times of your copper before you do.
Okay.
And KF ring was negative. She was only 45 years, and we looked at it. Okay. So all the viral serology is negative. What else you want?
Autoimmune workup, sir. ANA, IgG. IgG levels were 26, elevated. ANA IF was positive. Profile was negative. Liver soluble antigen negative, LKM negative, LC1 negative, AMA negative. So, if you see the score for autoimmune hepatitis score, ANA positive gets us 2 points. Infectious virology being negative gets us 2 points. And IgG levels being high. So she fits into probable autoimmune hepatitis.
Okay. What else you want now?
Now biopsy, sir.
Can we go to the biopsy? Can we go to the biopsy? No, just go to the previous slide. No, yeah.
comment on this.
Yes, ma'am. So the hepatic.
This is free hepatic vein pressure, not hepatic wedge pressure. Okay. Free
Yes,
hepatic
sir.
vein.
Free hepatic wedge pressure was 34, and the wedge hepatic pressure was 18. So the gradient was 16, which is high.
Okay. So we went ahead and did a transjugular liver biopsy.
Suggestive of portal hypertension. Clinically significant portal hypertension is more than 10. So you have
Had
to
some, but there was no varices in her.
yes, sir.
This is what the radiologist told us, that she had a high hepatic vein pressure. Okay. Can you go next, please? Biopsy.
Biopsy.
You can see a lot of lymphocytes, no? You can see ballooned
See a
out
lot of
lymphocytes.
Yes, sir.
Yes, you can see,
You can see some eosinophils. You can see
eosinophils.
infiltrating plasma cells here. The ducts are fairly all right. Can we get the next slide, please?
Yes, so second study shows liver tissue with extensive portal fibrosis. Hepatocytes are swollen and show intracellular and canalicular cholestasis. Foci of spotty necrosis, lobular inflammation, neutrophils and portal tract shows dense lymphocytic infiltrate with conspicuous plasma cells. Interface activity is observed. So diagnosis is right lobe liver, the biopsy was taken from, shows severe active hepatitis with extensive fibrosis, and autoimmune etiology may be considered.
So she had portal fibrosis. She had a lot of architecture. There were some cholestasis. So they said the cholestasis would have been due to a drug, but there's also a foci of spotty necrosis and lobular inflammation. Most importantly, there was interface activity with dense lymphocytic and plasma cells. So one possibility is that she might have had an underlying autoimmune hepatitis, or this could be a drug-induced autoimmune hepatitis, a possibility. Okay. Now I think she's still in the ward. She has been started on steroids, and she has been doing. We just looked at the CT just to make sure there was any other evidence of an underlying chronic liver disease in this patient. It was not there much. So again, this is a patient who had CAM, but presently probably has got a DILI-induced autoimmune hepatitis. Okay, that's one thing what they said. So the severe cholestasis, you can get sometimes focal cholestasis in autoimmune hepatitis.
What was the bilirubin in this patient? 20.
25.
25.
Any role for Plex, NVK? Plex?
We started on steroids. She has done very well, ma'am. She has not really gone into encephalopathy. And then she had only acute liver injury. So we didn't really consider. And she did well on steroids. I think she has done well on steroids. And bilirubin has started now, has come down to 16, I think. Dhanush is there. Dhanush is looking after that patient. So
Yes, sir. Bilirubin has actually come down to 12, sir.
12 now. She's on 30 milligrams of steroids now.
Yes, sir.
On this thing. So she has done well on steroids.
You can just tell the protocol at NVK for the autoimmune hepatitis. You have the sheet shut lock.
Hepatitis, the protocol is, one is what we go is by the Sheila Sharma. We give for 1 week, 20 for 1 week, 15 for 2 weeks, 10 for 1 week, and add azathioprine. Otherwise, you can even start 30 carb something and start azathioprine in the first time itself. Or the other protocol is you start 60 milligrams every day for 1 week, 50, 10, 50, 40, 30, and then start azathioprine. These are the 2-3 protocols which we have. Now, I think the ACG protocol, they start off azathioprine much earlier.
Yes.
We follow this.
What I wanted to ask you is this one difficult to differentiate, no? DILI versus
DILI versus autoimmune hepatitis. Since she had that interface plasma activity, IgG was elevated, ANA, IFS positive. Sometimes drugs can also produce. It's very difficult to say about.
Very difficult, exactly.
Can liver biopsy help in such cases where we find more?
Not really, sir. We don't know much. Biopsy helps in person. Only thing is, even in drug-induced liver injury, you can get sometimes eosinophils and all.
That's what I heard. Yeah.
The interface or spotty necrosis. But if you showed a pure canalicular cholestasis, John would have started steroids. But here, In this patient, there is a distortion architecture, there is interface hepatitis, there is lymphocyte infiltrate, there is plasma cells. Some of the drug-induced, I think next class we can put two more drug-induced where one has shown only canonical cholestasis in this case, and we don't really start the. But here the biopsy showed lymphocytic infiltrates plus plasma cells plus interface hepatitis. I think that's why we thought it may be autoimmune hepatitis or DILI-induced autoimmunity and put her on steroids. He has done extremely well on this.
If at all, sir, one question. If at all this biopsy had showed a predominant eosinophil,
Or if he has not showed interface hepatitis and lymphocyte plasma cells, we would have just waited, taken off the drug and wait for it. And as madam said, if she is not progressing, I would have plexed her probably. Okay. The good thing about autoimmune hepatitis, they respond very well to steroids, even though there is a portal fibrosis there. Okay. The only other thing is a portal fibrosis. The fibrosis after, I don't know whether fibrosis comes up so early, but sometimes they say it takes only about 21 days or 3 weeks to develop a fibrosis. Okay. So please read about autoimmune hepatitis, DILI-induced autoimmune hepatitis. Treat what are the changes, what are the treatment regimens in autoimmune hepatitis, and when do we do transplant, all those things. And what are the other drugs for autoimmune hepatitis if you are not responding to azathioprine or if you develop azathioprine toxicity? What is the role of second line management? What is the third line management? All those. Okay.
Thank you, sir.
thank you, sir.
I think for autoimmune DILI also we can give steroids, no? And they have good prognosis compared to the conventional autoimmune disease, where there's a chance of relapse.
The only thing we can't explain is the pain in this patient. No, the pain was the one that was distracting. But I think clinically we would just say drug-induced liver injury as the first go. No, and then autoimmune will be the number 2 differential. Close where it is DILI-induced autoimmune hepatitis.
DILI is probably the first and probably DILI autoimmune, plus or could be DILI-induced.
Yeah. And the rest and all will be reactivation and all that will come as viral hepatitis and other things. Common things will be common.
Some of the drug-induced liver disease, you need to look for reactivation of hepatitis B.
Reactivation.
Name the 2 drugs where you look for reactivation of hepatitis B.
Sai?
Can anybody name
Bhargav,
the
2 drugs
where you look for reactivation of hepatitis B?
Rituximab.
Yeah, rituximab, good. Okay.
Leflunomide can cause, which is used for rheumatoid arthritis. You can get reactivation of hepatitis B as jaundice, or leflunomide can cause autoimmune hepatitis. Okay, so these are things which you can do. What are the new drugs which cause autoimmune liver disease? Which are the new cancer drugs which can cause autoimmune hepatitis? Immune checkpoint inhibitors. Kindly look at all the complications of immune checkpoint inhibitors. You need to look at immune checkpoint inhibitors toxicity. You have 2 toxicities. One is colitis, another is hepatotoxicity. So kindly go through immune this thing. Somebody asked some questions. When do you look for see, somebody who's got IgG level. So whenever you are on treatment for autoimmune hepatitis, your goal is to bring down the IgG level to 12 in about 6 months' time. If you're not able to bring down IgG levels below 6 months' time, that means you are not responding to the drugs. So you need to look what are the things which are non-responsive, enzymes not coming down, bilirubin not coming down, IgG level are persistently high after 6 months.
VT, can you just mute? VT, please mute. Yeah. Yeah, LVK.
No, when do you say not responding? One, your enzymes do not come down, bilirubin does not come down. And if the IgG levels at the end of 12 weeks or 24 weeks does not come down below 12, that is what you need to look at it. So when you are on azathioprine, if you are not responding, then you need to look at whether patient is got azathioprine in compliance or they are non-responders. Then you go to change the second line of drugs. Okay. So you need to look at the TPMT, look at the mercaptopurine analogs, mercaptopurine thiaguanine levels, and decide whether they have compliance or no compliance. And next is you go for other drugs. Other drugs are you can use you can get mycophenolate mofetil, you can use tacrolimus, you can sometimes use cyclosporin in these patients. And of course, rituximab also can be used in these patients.
Thank you, LVK, for the nice two identical cases, but with two different types of.
Yeah,
I mean, they start with CAM.
Both have got a history of CAM.
Both history of course at CAM. Yeah.
One was.
But diagnosis goes as different. Yeah.
Other is two different biopsies which showing primary cholangitis. Other is autoimmune hepatitis.
Sure.
Mm.
Thank you very much. Thank you very much.
Thank you.
Thank you, sir.
BT, thanks a lot for joining in. There's
And
lots of questions.
Challenge. Why we thought so is penicillin challenge. We didn't want to waste time. She's 45-year-old lady. She did have CAM, but when your ceruloplasmin is not too low, but when your copper, sometimes what happens, the drug has caused some cholestasis. You can have increased copper excretion. But we thought we'll complete the investigation by a 24-hour deep and challenge. That's it. We want to do it because we don't want to miss anything in a patient who has come to us with 25 bilirubin and all those signs, and SGOT was elevated. That's the reason why we went. Above 100, we are little uncomfortable. But generally, when you are deepen, it will be 4 or 5 times more than this one. In a Wilson's disease, in a copper-related.
Thank you, LVK. BT, thank you.
LVK, your next class is on the 4th Thursday, no?
4th Thursday, sir.
Yeah.
Okay. Next week on the Kerala side, on Tuesday, we'll have introduction to the clinical aspect, like history taking and advice from senior teachers. And on Thursday, we have recent advances in gastroenterology. Okay.
Right. And we move on to the 4th Thursday for the clinics. No?
Okay.
So we'll. My next
4th Thursday
will be on 26th.
Yeah.
26th.
We have I have cases this side, so I will take up.
Okay, sure.
You can LVK, if you have a luminal case, take up one luminal. I'll give one liver from this side.
Sure, I'll look for something luminal.
Luminal
or pancreatic or something.
Something, yeah. Thank you.
Thank you, madam.
Thank you, and good night to all. Thanks, Bhargav. Thanks, Sai. All of you did well. Let's keep reading. That's all. Okay.
Thank you.
Bye-bye. Good night. Good night.